left with MH was 37%. So we thought maybe right appendectomy should be straightforward with her. But when we went in, this is the liver looks like. You can see this liver is very steatotic and steatohepatitic as well, with some looking bands as well. So we thought we'll just do an ALPS on her. So we did the transection, parenchymal transection, and ligated the right portal vein. And we went in after a week, and this is scanned after first stage, and then we went in again after a week. This is the hypertrophy of the remnant after the first stage, and we resected the right lobe of the liver at that time. Okay, so this is the final histopathology, multifocal epithelioid hemangioendothelioma. Okay, so just to come to what is the difference between these three modalities. So basically, when it comes to overall resectability rate, the ALPS is better, and but there is increased morbidity and mortality associated with the ALPS, and that's why that procedure has not become as popular as one would have thought. Although the hypertrophy is much quicker with ALPS, but it is not functional liver. That is which makes difference between PVE and ALPS. So ALPS can achieve a quick hypertrophy, but the function of that liver is questionable, and that's why there is increased morbidity and mortality associated with ALPS. So portal vein embolization is much safer, and but if you want to do, then you can do rescue ALPS like we did in this case as well. So these are the differences which I thought. So in terms of portal vein embolization, FLR volume is about 40%, function gain will be 50%, ALPS FLR volume will increase by 75%, function will be only 25%, LVD FLR volume of about 50% increase, and the function will be about 65% as well. Okay. Now last bit, this is about jaundice and cholangitis. These are associated with increased postoperative hepatic insufficiency, and especially if you have a remnant mode less than 30%. So if you have a perioperative bilirubin level of more than 3 and a remnant of less than 30%, there is increased risk of mortality associated with it. And so it is always good if you're planning to do a major liver resection, then you should drain. And patient, not always, but in a given case, if the remnant is less than 30%, you should drain. Then if cholangitis is not improving with antibiotic, patient has cholangitis, organ failure, then obviously you need to drain. Renal dysfunction, need to drain. In major hepatectomy with a bilirubin of more than 5, you have to drain. If you're planning to do vascular resection, again you need to drain. If obviously patient had neoadjuvant therapy and other parenchymal abnormalities, it's better to drain. Okay. Then there is controversy about ERCP versus PTBD, and the advantages and disadvantages are very obvious in terms of, but we prefer PTBD somehow if it is a HALA block and we need to drain, because most of the time the ERCP actually doesn't go into the right low way, and PTBD works well, but there is data both contrary to it, as data actually suggests maybe ERCP is better than PTBD. But so it is about center experience, how they want to do it. We prefer to do PTBD as well. Okay, so should be done under cover of antibiotic, and FLR should always be drained first. If you're planning to do portal vein embolization, then it's better not to drain that particular lobe of liver, because once infection sets into that part of the liver, then it will be very difficult. And that's one of the reasons why a lot of hilar cholangiocarcinoma becomes unresectable, because the sepsis doesn't go away. So you need to be careful there as well. Okay. And ideally, you should wait for bilirubin to come down less than 3 before you plan for the resection, and you need to, obviously, cholangitis need to improve, and nutrition has to be tackled during that time as well. Okay, so this is last bit, prediction and prevention of hepatic failure, post-hepatectomy liver failure. So these are the risk factors you need to look at. All those BMI, age, MAFLD, CASH, cholestasis, cholangitis, and clinically significant portal hypertension. You need to image properly to look at liver parenchymal abnormalities and volumetric assessment. then portal vein embolization, ALPS, and liver deprivation, as we've gone through, will help in optimizing these patients as well. Okay, so this is just to summarize. There is a changing spectrum of patient. There are more patients with MAFLD coming through for liver resection. We need to have adequate volumes in order to prevent failure. And volume is not just enough, need to assess function as well. And short period of lifestyle optimization can improve liver regeneration. And all these three techniques, PVE, ALPS, LVD, can increase the susceptibility rate and safety of liver resection. Each patient should be individualized and assessed to prevent post-hepatectomy liver failure. Okay. Thank you very much. Thanks a lot. I hope I'm not overrun. Not.
Thank you. Dr. Shaktivel, you can take up. Yeah. We'll have some discussion. Yeah.
Thank you, Mr. Sir, for such a wonderful lecture back with extensive evidence and your experience. The topic is now open to discussion. The delegates can type their questions in the chat box, or they can unmute themselves and ask the question. There is a question from Dr. Rohan Madhu. Is routine liver biopsy for donor recommended to rule out previously undetected steatohepatitis?
Sorry, did I hear that biopsy in donors?
Yes, doctor. Is routine liver biopsy for donor recommended to rule out the previously undetected steatohepatitis?
So we don't do it routinely. We will do it only if the imaging like ultrasound and fibroscan are suggestive of steatosis, which is more than 20%. So in those cases also, again, we will first put them through an optimization protocol, because that will be our first aim, to optimize them as much as possible. We'll wait, and obviously it depends on recipient condition. So if they can wait, then we will just wait for 3-4 weeks of lifestyle optimization. And then if the enzymes are still on a higher side, GSTLT is on a higher side, and fibroscan is borderline, then we will be tempted to biopsy. The other group in which we biopsy is relatives of autoimmune. So first degree relatives of autoimmune etiology recipients. Then some of the patients with core positivity, and supposing somebody who is 40 plus with core positive, HPV core positive.
If I get called in the middle of it, I may have to leave it in the science hope I don't get called. We've all done the arteries and everything, so we're just waiting for the final bit for the Doppler's to be completed. Is it alright if you share the slides?
Yes, please.
सब ट्रांसप्लांट ही कर रहे हैं रांची.
Professor Vijayanand is a clinical lead for HPB and transplant services at Leeds University Hospital. And he'll be delivering his talk on preoperative imaging in liver tumor.
Yeah, exactly. So we got one more. Website itself, where's the top certified?
Shakti, I'm just going to leave the meeting and join again. Just 1 minute. My laptop is just causing a privacy setting. I'll leave the meeting and I'll join again.
अब आपको जापान ले चलेंगे. जापान से आप था सिखाएंगे आपको. कोरिया से. वहीं कोरिया वालों से मिलना. ड्रामा देखती रहती.
Right, sorry Shakti about that. I think we'll start sharing it now. Can you see the slides?
We can see your slides.
Evening, everyone. I'm Parthiban. I'm one of the fellow here in Leeds in a triple area on liver transplant. Today's topic is role of imaging in liver surgery. So coming to the introduction, we know liver resection has significantly advanced in last 50 years, leading to the excellent outcomes. It's because of the involvement of various departments like anesthesia and radiologist and surgeons improving as well. The multimodal imaging provides a comprehensive understanding of anatomy and facilitates surgical planning for curative procedures. So managing these patients requires a skilled multidisciplinary team, especially specialist liver radiologist. As nowadays we are getting frequent incidental imagings, we might need a friend in that department to help out the further planning in terms of follow-up imaging or treatment. So this talk will discuss the role of imaging in liver surgery and its impact on surgical planning and how it enhances the patient outcome. So coming to the role of imaging, so mainly it is to characterize the lesion so that we can know what is there, and also to know the tumor extent and burden, and to stage the disease if it's malignancy, and assessment of vascular and biliary anatomy, surgical planning and feasibility, and also the treatment efficacy, and diagnose and manage complications. So coming to characterization of lesions, it's mainly to diagnose what's there in the liver. So we have benign and malignant lesions. Most common benign lesions are hemangioma, complex cyst, or a simple cyst, or FNH or adenoma. And other side, we have malignant lesions like hyalocholangiocarcinoma and hepatocellular carcinoma, and also frequently colorectal liver mets and other metastases. The modalities we available to diagnose these things are ultrasound. It is the primary tool for assessing focal liver lesion. It is fast. It's widely available. However, it's operator dependent and lacks a panoramic view. So coming to the CT scan, in terms of liver imaging, we need three phases like late arterial phase, portal venous phase, and delayed phase. It is time based on time of contrast. So portal phase is around 60 to 90 minutes. Delayed phase is up to 5 minutes. Coming to MRI, it includes T2 weighted and axial T1 weighted image. Also the in and out of phase with diffuse and weighted imaging, and MRCP with post-contrast acquisitions.
I think the key part in this part is the characterization of the lesion, is how you can make an impact in terms of your diagnosis of a liver lesion. Nowadays the scans are done widely, and many people get the scans for other reasons, and often 30 to 40% of the cases that you're going to see or come through the incidental diagnosis of lesions. That could be anything from benign to malignant cases, but as an expert, you probably would need to differentiate what that lesion is. Hence, when we talked in the first slide, multimodality imaging is key in terms of determining whether it's a benign or malignant cases. Often these images will help you to decide on the further management. You can just reassure the patient if there's no need for further surveillance or surgery. Then, or you come up with some lesions where they have some atypical appearances where you may have to keep them on a close surveillance with agreed interval imaging. Or you think about something that needs to be operated on based on what you find on the scans. So essentially, imaging is very, very important in liver surgery, when especially comes to diagnosis as such from the beginning, and able to differentiate between different lesions is very, very important. Just give you an example, if you look at these benign lesions, you do see hemangiomas very commonly in ultrasound scan. Often the ultrasound scans are pretty good in diagnosing hemangiomas, but many times it's all operator dependent. Many would call an hemangioma as a focal liver lesion, unnecessarily panicking the patients and leading further investigations. That can be true in certain atypical hemangiomas, where sometimes the sclerosed hemangiomas can present differently. Similarly with complex cysts, we do see many complex cysts in terms of the important ones are the mucinous cystic adenoma and also the foregut ciliated hepatic cyst. Those are the cysts which have preponderance or risk of transition into malignant in the future. But though the risk is 5 to 8%, but still it's important that these patients are managed accordingly. Similarly, if you got a focal nodal hyperplasia, MR can do it. MR is the best investigation tool to diagnose focal nodal hyperplasia. Often focal nodal hyperplasia do have a characteristic features on an MRI scan, and once that radiologist is quite happy to diagnose FNH on an MR, the patient just needs a reassurance if they are female. But I should give you a caution. If you see a focal nodal hyperplasia in men, I think it needs to be in a different spectrum where the risk factors change. So it's vital all these images are considered in tandem to make a valid assessment of a patient.
So coming to how the various enhancements and the imaging help us in characterizing the lesions. We know the common benign lesion is hepatic hemangioma. We can see the CT shows the peripheral nodular enhancement with centrifugal pilling on the delayed phase, as well as it will show in MRI it will be a T2 hyperintense and delayed enhancement will be present in hemangioma. So coming to FNH, so strong artery seen on CT, and the central scar, it is present in around 60% of the patients, so it helps us in diagnosing the FNH. There is intense delayed enhancement on MRI, which helps us diagnosing in FNH. Say even if it is atypical, we would further warrant, if it is atypical, we might have to rely on biopsy. So coming to the other common benign lesion is hepatic adenoma. So it has arterial phase enhancement, and there is no delayed enhancement. Sometimes it is difficult to well differentiated carcinomas might require background of the patient or background disease, probably sometimes require a biopsy.
Again, in this, as a word of caution, you have to assess the sex of the patient. Whether it's a female patient in a reproductive age group using contraceptive pills is very common to see them, and it's also got some association with metabolic syndromes. The question here arises if you see hepatic adenomas in men, and that's where I think the alarm bells should be very cautious. In those things, you can't just have one assessment tool for these patients, where the men hepatic adenomas often can be confused as hepatic adenomas could actually be a well-differentiated HCC. So in those scenarios, if the patient is fit enough and thinks, if you think that there is an adenoma which is resectable in men, as you would go as a first tool of resection. The other criteria they use for the hepatic adenomas are mainly about the size-wise. If you got a 5 centimeter or more, the risk of bleeding is higher. Hence, we do manage them differently rather than subject them to surveillance. So lifestyle changes and other aspects comes into management plan of these cases.
So this is the interesting case. We encountered the patient with multiple hepatic adenomas. It was quite difficult to diagnose on CT scan, and we relied on MRI, which has showed internal fat. Still, it is somewhat atypical. Probably will need a biopsy.
The one thing about this, again, we showed this is a male patient. We can't put the details on the slides, I'm afraid. So this is a male patient with multiple hepatic adenomas. And you can see the biggest one is on the right lobe, which is about 8 centimeters. We couldn't show all the images together. He's got all segments, has got hepatic adenomas, no segments are spat in his liver. So the primary point here is a male patient with multiple hepatic adenomas. The alarm bell should be started ringing. Is there any malignant transformation? The patient does have a use of anabolic steroids. The use of anabolic steroids, which is a good history you can get from the patient, does predispose to high risk for hepatic adenomas transforming into HCCs. So in this scenario, we did biopsy one of the major lesions to assess whether there's any transition of malignancy, but we did find that there is a beta-catenin mutation positivity staining. So this is something that you have to delineate, because in the MR, we need to differentiate between whether these adenomas are transformed into an HCC. So a good MR with different phases of contrast is vital, and an expertise liver radiologist to go through these scans and give you vital information in regards to the planning of the next management course. Because given that he's got adenomas throughout the liver, if one of these lesions do translate into a HCC, then this patient can't have any surgery because it's outside the transplant criteria. At least if you're able to biopsy these patients and able to establish the diagnosis on the base of the scan as well as the tissue diagnosis, at least these patients can consider for a liver transplantation in order to avoid these lesions being translated into malignancy at a later date.
So this is coming to HCC. We know HCC, it looks hypoechoic on ultrasound, but in classical feature is arterial hypervascularity, and there is a total venous washout. And as you can see in the imaging, there is a complete washout in the delayed phase. It looks more hypodense than the original liver. So that goes for HCC.
So what Parthiban is showing you is about to come to the malignant part of his, which is one of the commonest primary malignancies, the HCCs, which is more prevalent in patients with chronic liver disease. And again, it's quite prevalent even in the Western as well as Asian continents. The criteria is there are several criteria being established, and there's well-validated tools to diagnose HCCs. I'm aware even Biju's got some AI involved in diagnosing the molecular features on a CT scan with special investigation softwares to assess that risk. A good triple phase CT is good enough to diagnose an HCC. We don't need any further modality, but I should say our practice is, even though we get a good CT to establish number of lesions, we do go for MRI scan, because CTs, though they are good, but if there's anything sub-centimeter, they're not able to pick up on a CT scan. Hence, the MRI scan in these patients are very vital important for us to differentiate how many nodules, and usually formulate a LIRAD score, which Parthiban will show you in the further slides.
So coming to the other important malignancy is intrahepatic cholangiocarcinoma. So the image shows that it's peripherally located. There is a capsular retraction, which is a very typical feature of intrahepatic cholangiocarcinoma, and also periphery ductal dilatation as shown in the pictures. And also this, it's progressively enhanced the phase as the arterial phase delays. So coming to the next. So the other important malignancy we frequently encounter in UK is colorectal metastasis. So we can see this hypoenhancing with the diffusion weighted changes, and also peripheral enhancement in the arterial phase, which phases out on the venous. Yeah.
So the next bulk of liver surgery is mostly done for metastasis. Increasingly, not just about the colorectal liver metastasis, we're increasingly doing liver surgery for oligometastatic disease and concerning with whether breast metastasis, melanoma metastasis. We've been doing all the neuroendocrine tumor metastasis, and we've also been doing some lung metastasis in the liver as well, be managing them in different ways. More often, based on the primary that is involved, and I think a good MRI scan and a good wide whole body CT scan is good to scan investigations to essentially assess the tumor load and the burden and the surgery that you could plan. Occasionally, sometimes you would need a PET CT, though it's not required in every cases. A PET CT is used in a selective cases where you may have some doubts about on the scans that you already got obtained.
पढ़ाई कर रहे हो ना?
So that's the characterization. Now, the importance of tumor site and size and burden. We know the foundation of liver surgery is it relies on the intrahepatic anatomy and accurate tumor resection, and the quality of parenchyma, and ensuring the sufficient vascular and biliary inflow and outflow for avoiding post-operative liver failure. So coming to tumor burden, why it is important. So in terms of HCC, by knowing the location of tumor, how much how many tumors are there. So if it is in a cirrhotic patients, the numbers are important for to come under the criteria routine and UCSF. In India, it's up to 7 criteria for transplant. If it is a non-cirrhotic or it's child A with a single lesion or a double lesion involved in a particular lobe, then we can offer resection. So coming to high-level cholangiocarcinoma, so with the help of imaging and location, we can classify the tumor so that we can decide on the extent of liver resection, to decide on whether to do a left extended or right extend based on the location. So again, as discussed before, colorectal liver mets, it gives a burden how much lesions are there, especially MRI shows subcentric lesions and accurate location, and also anaplastic or extended resection, that is FLR adequacy. So these are all things we can see by tumor burden and surgical consideration. So why it is needed? So it's to optimize the surgical strategy. By knowing the disease burden, we can decide whether it is resectable or it is unresectable, whether we should go for a palliative pathway. So and also by looking at the liver remnant, we need to whether we have to optimize our future liver remnant. We have to do porcine embolization, or if it is high tumor burden, we might have to opt for ABS or a two-stage hepatectomy.
I think the one main story is in this day and age, I don't think anyone can operate on a liver without an appropriate imaging being available and have an accurate assessment of the disease burden. It's essential to safeguard and also to achieve the best outcome in cohort of patients. Scans can also be beneficial, especially when you had patients had chemotherapy beforehand and had some lot of downstaging chemotherapy. In those scenarios, you don't know how kind of issues can happen. Certain chemotherapy regimens do cause problems with the liver, and MRI is a very good tool to assess what the background liver looks like and whether this is heterogeneous or homogeneous, whether there's a perfusion problems, how bad the steatosis is, and that will establish you how safe we can resect, especially when you're considering a major liver resection.
So coming to hepatocellular carcinoma, as discussed before, MRI performs better than compared to CT in detection of HCC, especially in liver cirrhosis. When we have particular hepatobiliary contrast and phase, it even identifies the subcentric lesions. So the LIDAR's definition of typical imaging features includes arterial phase hyperenhancement, washout appearance, and enhancing capsule. This is a systemic way of reporting to report the HCC in background liver disease.
And it is the only validated tool to give you a radiological diagnosis of a primary liver cancer. If you look at any other diagnosis, don't have these sort of extensive assessment tools. HCC is what diagnosed radiologically, and this is where I think these tools are essential to diagnose such things.
So we know that LR1 is definitely benign, and LR2 is probably benign. LR3 is intermediate. Problem is LR4, probably HCC. LR5 is definitely HCC. LRM is probably or definitely malignant, and not HCC specific. TIV is tumor in the vein. So this gives a systemic way of reporting the HCC.
So just one more things. There is also things, once the patient had some sort of local regional treatment, you're going to do some scans to assess the treatment efficacy. That's where I think Bharti has put on the LRTR. I think those are to assess the response to local regional treatment and see is there any viable tumor still left in the treated area. Either it's following an ablation or following a TACE treatment or even after SPRT or TAR. So these are tools that are defined so that when we come as a clinicians, we can able to establish in terms of what's next for these patients. Hence, a good scan will give us very vital answers for us to help in managing these patients safely.
So coming to cholangiocarcinoma, so British Society guidelines have recommended both CT and MRI, CT to comprehensively assess the primary tumor location and its vascular relationship and overall resectability. especially mass forming intrahepatic cholangiocarcinoma. MRI with epitobiliary contrast is more accurate for identification of satellite lesions, which we frequently see in ICC. So for intraductal or periductal or perihilar tumor, especially in the setting of violet obstruction, it's better to use extracellular contrast agents in MRI. So perihilar tumors, MRCP with contrast enhanced MRI helps to delineate local extent of the biliary involvement, the thickness we will identify to determine the dissectability and for planning the biliary drainage of IFLR. So these are all the recommendations from British Society that has shown that for primary contrast enhanced CT, it is strongly recommended, and MRCP is for biliary involvement and also to see satellite lesions. And coming to PET CT, it's if we are expecting a metastatic disease or high tumor markers are there, it's PET CT will show the nodal or distant metastasis.
I know for some centers do routinely do PET CTs for cholangiocarcinomas, but though if you got a good CT scan, contrast enhanced CT scan, as well as an MRI scan, where you be able to differentiate and assess properly, you don't need a PET CT. PET CT is only done if you have any doubts in those images. That's our usual practice.
So coming to colorectal liver metastasis, most of them will go for a neoadjuvant chemotherapy, and sometimes after when they come for the surgery, you won't even find metastasis on imaging. So the term disappearing metastasis is defined by European HPBA has shown that the baseline contrast are no longer visible on epitobiliary contrast after a systemic therapy. The presence of scar on cross-sectional images terms evidence of treatment response. If it is visible in the contrast MRI, then the lesion is not considered disappear. We frequently see the tumors are responding very well to the chemotherapy, but during surgery, with the help of intraoperative ultrasound, we can see in a hypoechoic area where the treatment response has happened. So with that guide, we can do the resection. Coming to this trial, why it is MRI is mandatory before a colorectal liver metastasis. This study has shown that there is a change in treatment when MRI with the contrast is used, the contrast is used, and they've seen the treatment change and the way the extent of the resection has changed. So they have recommended liver contrast should be considered in all patients. They are planned for colorectal liver metastasis on the basis of contrast CT.
It is our usual practice for any metastasis we do. We always have a liver MRI done, and without the liver MRI, we would not consider surgery for these patients unless you're extremely claustrophobic or got some sensitivities to MR-specific contrast agents. So it's very essential that we do use MR in every case that we operate for metastasis, especially.
So this is Mavis software. It is frequently used in most of the centers to see the intrahepatic biliary and vascular anatomy, as well as to see the tumor burden, and it's essentially 3D reconstruction. So it's coming up. It should be widely used in most of the high volume centers.
I think the current software that comes with the scanners is pretty good in terms of they be able to accommodate and provide a lot of things that you could play with those softwares to assess the individual segmental portal and arterial and biliary anatomy. And that helps us to predict in terms of, because liver has got very common to see an aberrant anatomy, not just about extrahepatic vasculatures, even in the intrahepatically between the sectors. These tools are really helpful in terms of make yourself prepared for the eventualities that you may encounter during the surgery. If you have got access to these tools, please use it. I think it's much more vital, and it makes you more confidently able to do the resection safely.
So this is a few interesting cases in our center. This is a huge hepatocellular carcinoma, an 80-year-old lady, which was operated a couple of years back. So with the help of imaging, and we know what to anticipate before going in, and we schedule with the and the surgery and how to approach the lesion, like taking early control of the vasculature before mobilizing the liver. In that way, the imaging helps, and this is the post-resection imaging, and she's doing well now. So this is an unusual large lesion arising from a caudate, and it's reaching up to middle and left hepatic vein, and also compressing the left portal inflow. So this we know that is a challenge. Before going in, we will know challenging surgery. We can anticipate whether to do a resection or to do a left appendectomy.
I think here this is what this picture is. Sometimes you do get challenged by the sort of cases that comes through the doors. I think this patient was just presented to us 6 months ago. I saw her in the clinic, and she's, as usual, as it is, the hepatic angiomyolipomas are rare, and often they're smaller in different places, but this one is quite huge, about 15 centimeters. And also it's been arising from the caudate lobe, initially whether there's a differential of a sarcoma or other things, or leiomyosarcoma arising from it, but when there is a biopsy done in this case, which clearly gives you a diagnosis of angiomyolipoma. Now, the challenge part is it's in the caudate, it's in the centrally located, it's pressing on the hilum and almost disappearing, and by the left lateral segment, as you can see, is lifted up, and it's all pressing on the bile ducts going into the left side, as well as the vasculature going into the liver. The key thing is, again, you got the middle hepatic vein is just beneath the tumor, just on top of the tumor, as well as the left hepatic vein, and it's also abutting the right hepatic vein. So these are the things that you prepare yourself, and the imaging is vital, and having a good information, it helps you to plan the surgery very well. We did resect that patient, and we just managed to take it out without compromising other things, and the patient did well. And the diagnosis again confirmed as an hepatic angiomyolipoma.
So this is to show the importance of MRI in colorectal liver mets. You can see MRI. This is a CT in A showing that single lesion near the gallbladder, but in MRI we can see another lesion on the surface of segment 6. So that's why MRI is more accurate for colorectal.